to see the degree to which, as I say, 30 years ago, the supersensitivity psychosis theory, and I'd like you to mention a little bit about that, that how much information was there beforehand? And of course, when you look at the facts that before schizophrenics were regularly tanked up with these medications, you had 65% of first episode schizophrenics could be discharged within 12 months. And the majority of those discharged would not be rehospitalized in follow-up periods of 4 and 5 years. And of course, they didn't have the cognitive declines, they didn't get the facial tics, they didn't get all of the other health issues. As you say in the book, it's between 15 and 25 years cut off the lifespan of people on these in this track. I mean, it's staggering the degree to which this was known for many decades. And I mean, outside of your books and other work that's been done, it's simply not part of the common calculus in society.
Right. You know what's amazing? What you're getting here to is the way in which our society has become deluded, and really, it's a really sort of remarkable societal delusion. And just take the schizophrenia story real quickly. If the concept of schizophrenia goes all the way back to the early 1900s, and even a little bit to the late 1800s, with a Swiss psychiatrist or German psychiatrist named Emil Kraepelin. And he had this group of he looked at all his psychotic patients in his hospital, and he divided them into two groups. He had one group that showed up, they presented with psychosis, but also they showed some affect, some emotional engagement. Now, if you actually go back to Kraepelin, that group got better long term. There was a second group of psychotic patients that were very dilapidated. They were withdrawn. They had trouble making willed movements. And it was just that smaller group of psychotic patients that didn't do well long term. Now, what becomes clear in history is that group of patients that Emil Kraepelin saw, many of them actually had a viral illness called encephalitis lethargica, but that virus had not been identified at that time. The virus gets identified around 1917, and once that virus gets identified and doctors start recognizing this presentation as a viral story, the definition of schizophrenia changes, actually. And now, oh, sorry, I know this is confusing. Anyway, it was that group of patients, that psychotic group that presented with a lack of effect, that had a bad long-term outcome. Kraepelin found that if you present with effect, with emotion, that's a good outcome. The confusion arises because after the virus is identified, then schizophrenia gets a new definition, and basically it's just seen as psychosis. And doctors say, aha, remember, schizophrenia has a bad outcome. But that was a different group of patients. So what I did in this book is trying to understand is, well, if we look at how were people diagnosed with schizophrenia faring, say, in the decade prior to the introduction of chlorpromazine, you have this extraordinary surprise. And you find that, as you said, 60-70% would be discharged from mental hospitals in 12 to 18 months. And then when they would follow those cohorts 5 years later, about the same number would be, percentage would be living independently in the community. About a third just wouldn't be, quote, schizophrenic anymore. They'd have no symptoms. But the employment rates were above 50%. And we completely forget that sort of relatively decent outcome. Now, going forward with the story that you were talking about, supersensitive psychosis, when people learned that, or sort of sensed that something was going wrong, you're right. In the 1970s, after about 20 years of the first generation psychiatric antipsychotics, you see the leaders in the field going, oh my goodness, people are relapsing more frequently than before. That's number one. Number two, they said, listen, we have discovered how our drugs work, the first generation antipsychotics, and they work by blocking dopamine receptors in the brain. They thwart this dopamine transmission. But what they had also come to see was that in response to that blockade of dopamine transmission, the brain tried to up its dopaminergic system. And I don't want to get too technical here, but basically the neurons put out more dopamine, and the neurons that receive the messages increase the density of the receptors for dopamine.
Don't be alarmed of details. I have a pretty smart audience. So.
Okay, but you know, it's sort of technical stuff. But so now they said because the brain is trying to compensate for the brain's presence, the brain is super sensitive to psychosis, and as a result of this brain change, you have two things. When people come off the medications, they're now more vulnerable to relapse than if they had never been on the medications in the first place. That's number one. But two, even if they stay on the drugs because of this brain change long term, they're vulnerable to what's called tardive psychosis, in which the psychosis sort of settles into the brain and becomes more permanent. That's the early 80s. And so by the early 80s, researchers were saying the drugs do something. Here's how they act on the brain. In response to the drugs, the brain is modified in this way. And when we have this modification, the brain is now more vulnerable to psychosis than it would be in the normal course of, quote, the illness. In other words, you were increasing or exacerbating the underlying biological vulnerability to psychosis. And you even see researchers going, and when this happens, symptoms can become more severe, more debilitating. So yeah, it shows up in the 1980s. And then what happens is that the only way to put it is that, and it's really American psychiatry entered into a partnership with the drug companies in which they decided they'd sell a certain story. And that was a story of drugs that fix chemical imbalances and a story of great advance. And so they had to sweep under the rug this type of research that was showing this paradoxical outcome.
And sorry, just to mention what you talk about, I think, in the book, which is kind of chilling, is the degree to which psychiatrists in the 70s, and you mentioned that I think only 4% of residents were heading into psychiatry because it was becoming somewhat discredited, and also they were facing a lot of competition in talk therapy, which is what they were focused on at the time, from social workers and psychologists and just regular old therapists. And so, in a sense, they reached for the prescription pad because it was the one rent-seeking differentiator that they had from all of these other people who were able to provide very similar services. So, in a sense, to keep their income, to keep their prestige, they really had to go to the prescription pad. Is that a fair assessment of what you found?
Yeah, absolutely. I mean, I think so. Just to, as we're going through this story, so you see this worries arise in the 70s, and it's even more than worries, sort of a confirmation of what's going on. And it happens in depression as well. So why don't we keep on hearing about it? And why didn't psychiatry keep on doing research to flesh out this paradoxical long-term effect? Well, it goes to what you're talking about now. And that gets us into this explanation of the monetary factors that control psychiatry storytelling. And here's that story. So up in the 1970s, psychiatry had its Freudians, it had some engagement in talk therapy, etc. But in terms of a couple things were happening. One, there was a lot of anti-psychiatry movement during the 70s, which was sort of treating psychiatry as sort of an agent of social control. So that made them a bit unpopular. There were some sort of presentations of psychiatry in the media, sort of the crazy shrinks as well. But more important was this. There was a big boom in sort of the therapy marketplace. Psychologists began offering, there were a lot more psychologists offering therapy. There were social workers. So now all of a sudden psychiatry, those giving talk therapy or doing psychoanalytic therapy, found themselves in competition with psychologists, social workers, right? So just in terms of the marketplace, they're now competing with people that can undercut their price, so to speak. So they say to themselves, what can we do to give ourselves an advantage in the marketplace? And it's quite obvious. They have prescribing powers. These other groups do not. So to give themselves an advantage in the marketplace, they have to make sure their prescribing powers have a value. Now, the other thing you referred to is, the other thing was in the 1970s, is psychiatry was seen as not a real medical, they weren't real doctors, so to speak, right? And their therapies weren't seen as very effective. And so medical residents weren't choosing to go into psychiatry either. So you hear this stuff in the 70s among psychiatrists saying, we're in a fight for our survival. Psychiatry's in a crisis. And the way they resolved those dual crises, which was that some residents didn't want to become psychiatrists and also the marketplace competition, is they came up with DSM-3, Diagnostic and Statistical Manual 3, in which they declared to the world, mental disorders are brain disorders, just like heart disease or cancer, etc. And then they began setting up a PR arm, the American Psychiatric Association, to start telling this story. And part of that PR machinery was to tell about how great the drugs were and how they fixed chemical imbalances and how they were making these great advances. And that PR story now gets funded in part by the pharmaceutical companies, because you can see the storytelling interests now are completely aligned. and we can go from there. But yeah, what happened was in 1980, the American Psychiatric Association said, we will tell a story of brain diseases. We will tell a story of our drugs that are very effective. And even though our research may be saying something else, and anybody who does not get on board within the profession will face basically some ostracization. They'll sort of be treated like lepers. It won't be a way to get ahead. And then the final part of the storytelling was pharmaceutical companies in the 80s began hiring American academics, in other words, psychiatrists at academic medical schools, to be their speakers, advisors, consultants. And once that happened, once that joining happened, and once academic psychiatry began serving as speakers for the pharmaceutical industry, we began to get this extraordinarily distorted story. And those speakers, and we place our trust in academic psychiatry to be, the honest storytellers, but instead they were sort of, they were telling a story to benefit the growth of a pharmaceutical market.